The ECMO machine suddenly stops and the air in line alarm triggers. You see a large bolus of air in the arterial return line. What is your first action? A. Increase the RPM to push the air into the patient. B. Immediately clamp both arterial and venous lines. C. Aspirate the air from the oxygenator vent. D. Lower the patient's head, Trendelenburg. Answer: B. Immediately clamp both arterial and venous lines. Explanation: this is a catastrophic emergency. You must clamp the lines immediately to prevent the air from reaching the patient's arterial circulation, which could cause a stroke or coronary embolism. Once clamped, you can work on de-airing the circuit. You notice a small, stable clot in the venous, pre-pump, bladder or header. What is the most appropriate management? A. Immediate emergency circuit change. B. Increase the heparin dose and monitor for growth or hemolysis. C. Tap the line to see if the clot will move to the oxygenator. D. Decrease the pump flow. Answer: B. Increase the heparin dose and monitor for growth or hemolysis. Explanation: clots on the venous side are common and are usually trapped by the oxygenator before they can reach the patient. If the clot is stable and not causing hemolysis or flow obstruction, it is often managed conservatively with increased anticoagulation. You hear a loud, grinding noise coming from the centrifugal pump head, and the flow starts to fluctuate wildly. What is the most likely cause? A. Patient is hypovolemic. B. A large clot has formed inside the pump impeller. C. The sweep gas is too high. D. The battery is low. Answer: B. A large clot has formed inside the pump impeller. Explanation: a grinding noise, often called the marble in a blender sound, indicates a mechanical failure or a large thrombus within the pump head itself. This requires an immediate switch to a backup pump or a circuit change. A patient on VV-ECMO for ARDS has a PAO2 of 350 mm of mercury. The medical team wants to reduce the risk of oxygen toxicity. Which setting should be adjusted? A. Decrease the sweep gas flow. B. Decrease the FIDO2 on the ECMO blender. C. Decrease the pump RPM. D. Increase the PEEP on the ventilator. Answer: B. Decrease the FIDO2 on the ECMO blender. Explanation: the FIDO2, fraction of delivered oxygen, on the ECMO blender controls the oxygen concentration of the gas entering the oxygenator. To lower PAO2 without affecting CO2 removal, you should decrease the FIDO2. During a circuit inspection, you notice a small crack in a stopcock on the arterial side of the oxygenator. Blood is slowly oozing out. What is the primary risk? A. Air embolism. B. Exsanguination and circuit contamination. C. Hypocapnia. D. Increased delta P. Answer: B. Exsanguination and circuit contamination. Explanation: because the arterial side is under positive pressure, air will not be sucked in. Instead, blood will be pushed out. This can lead to significant blood loss and provides a portal for infection. The stopcock must be replaced using sterile technique. A patient's hematocrit is increased from 25% to 40% via transfusion. How does this affect the ECMO circuit mechanics? A. Flow will increase because of better volume. B. Flow may decrease slightly due to increased blood viscosity. C. Delta P will decrease. D. CO2 clearance will stop. Answer: B. Flow may decrease slightly due to increased blood viscosity. Explanation: centrifugal pumps are sensitive to the viscosity of the fluid. Higher hematocrit increases viscosity, which increases resistance and may cause a slight drop in flow for the same RPM. You notice the patient's core temperature is dropping despite the ECMO heater being set to 37 degrees Celsius. The SpRIO2, venous, is 95%. What does this suggest? A. The heater-cooler unit is broken. B. Severe recirculation is preventing the warmed blood from reaching the patient's core. C. The patient is in septic shock. D. The sweep gas is too cold. Answer: B. Severe recirculation is preventing the warmed blood from reaching the patient's core. Explanation: if oxygenated and warmed blood is recirculating directly back into the drainage cannula, it isn't circulating through the patient's body. A very high SpO2 combined with poor temperature maintenance is a hallmark of significant recirculation. A patient on ECMO is being turned for chest physiotherapy. Suddenly, the pump flow drops from 4.5 liters per minute to 1.5 liters per minute and the venous line starts chattering. What is the first step? A. Increase RPM to 5,000. B. Immediately return the patient to the supine position and check cannula position. C. Give 2 liters of saline bolus. D. Call for a surgeon to recannulate. Answer: B. Immediately return the patient to the supine position and check cannula position. Explanation: patient movement often causes cannulae to shift or kink. In this case, the turn likely moved the drainage cannula against the vessel wall. Returning the patient to their previous position is the fastest way to restore flow. The sweep gas hose becomes kinked and flow drops to zero. How will this manifest in the patient's labs? A. Rapidly rising PaCO2 and respiratory acidosis. B. Rapidly falling PaCO2 and respiratory alkalosis. C. Sudden drop in hemoglobin. D. Rising LDH. Answer: A. Rapidly rising PaCO2 and respiratory acidosis. Explanation: ECMO clears CO2 extremely efficiently. If the sweep gas flow stops, CO2 removal stops immediately, leading to a rapid, and potentially dangerous, rise in PaCO2. Over the last 24 hours, you have had to increase the FiO2 from 50% to 100% to maintain the same systemic SpO2. The flow and sweep gas are unchanged. What does this signify? A. The patient's lungs are improving. B. The oxygenator is losing its efficiency, exhaustion/failure. C. The patient's metabolic rate has decreased. D. Recirculation has decreased. Answer: B. The oxygenator is losing its efficiency, exhaustion/failure. Explanation: when you need more effort, higher FiO2 from the machine to achieve the same result, the membrane is likely becoming coated in fibrin or wetting out, indicating it is nearing the end of its functional life.